Hello, my name is Nurse Engee. Today's topic is septic shock. It begins with an infection, something as simple as pneumonia or a urinary tract infection, but within hours, the body's defense mechanism spirals out of control. Blood pressure drops, organs begin to fail. This is septic shock, a life-threatening emergency. Septic shock is an exaggerated immune response to a microorganism that causes vasodilation. As you can see in the image, we have an increased blood vessels diameter, increased blood flow or decreased blood pressure, as well as increased capillary permeability, most commonly triggered by gram-positive or gram-negative bacteria. The immune system releases inflammatory chemicals that cause widespread vasodilation. Blood vessels widen and blood pressure drops. At the same time, capillaries become more permeable, like a leaky garden hose. Fluid escapes into the surrounding tissues, called interstitial spaces. The result: blood, oxygen, and nutrients can no longer reach vital organs effectively. Perfusion is altered and organ failure begins. What are the clinical features of septic shock? Clinically, septic shock presents dramatically. Patients may develop fever or, in the elderly and very young patient, hypothermia. Blood pressure drops dangerously low. The heart compensates by beating faster. Tachycardia develops. Despite IV fluids, hypotension persists. The leaky vessels prevent proper circulation. Early on, the skin may appear warm and flushed, but as septic shock progresses, it becomes cold, molted, and pale. The brain suffers from poor perfusion. Confusion, agitation, and altered mental status automatically occurs. The lungs struggles, acute respiratory distress syndrome, ARDS, may develop. The patient begins to hyperventilate, trying to compensate. Clients experiencing septic shock will often have persistent hypotension, even with fluid administration, because fluids are not getting to the proper places. For the same reason, we are going to have bounding pulses resulting to tachycardia. If clients are not getting enough oxygen to the tissues and to the blood, acute respiratory distress syndrome can occur. If we are not getting enough blood and oxygen to the lungs, they are not going to be able to function properly, and clients are going to be in a state of distress. Now, remember I said that blood and oxygen are not going to be getting to where they are needed, and this includes the brain. So these clients are going to have impaired cerebral perfusion and may begin to have acute mental status changes. Clients with septic shock will also have skin changes. Initially, they are generally warm and flushed, but as septic shock progresses and that leaky hose gets worse, their skin is going to become cold and molted. So our body is going to start in what is known as SIRS, or Systemic Inflammatory Response Syndrome. And SIRS can occur to any sort of trauma or assault or injury to the body. It doesn't necessarily need to be from infection, but an inflammatory response. Nonetheless, it's going to cause fever, tachycardia, and tachypnea. SIRS becomes sepsis when we have the features of SIRS plus an identified infection source. So if a client has pneumonia or UTI, they can be ruled in for sepsis. Septic shock is going to occur when we have the signs of sepsis plus hypotension despite adequate IV fluids. Remember the leaky hose phenomenon. It won't matter how much fluid we are giving, because that fluid is not getting to where it needs to go. And finally, septic shock can progress to MODS or multiple organ dysfunction syndrome. This is incredibly life-threatening because we have damage to multiple organs within the body. Like we talked about earlier, if blood is not getting to the lung, acute respiratory distress syndrome can happen. Our kidneys are very sensitive to alterations and perfusions, and the body is not going to be able to make enough platelets, so our platelet count is going to be low. When it comes to septic shock, clients will generally have similar lab values regardless of cause. They are going to have leukocytosis because there's an infection. Blood cultures are going to be positive for bacteria and high white blood cells. Remember earlier, we said that gram-positive and gram-negative bacteria are the main causes of sepsis. Increased stress on the body is going to activate the sympathetic nervous system, and our blood glucose level are going to do what? Increase. If the body doesn't have enough oxygen from metabolic processes, it's going to result to the anaerobic metabolism, and as a result, lactate is produced. As sepsis progresses, lactic acid levels are going to increase in the blood. These clients are going to have alteration in coagulation numbers, putting them at risk for disseminated intravascular coagulation or DIC. Exposure to procoagulants or bacteria will activate the coagulation cascades. The body is going to create and send clotting factors to areas of the body in response to the bacteria and the trauma. This is going to use up all coagulation factors and not leave anyone available for other processes. This can result in widespread bleeding, such as oozing from the IV insertion sites and places like the nose or the gums, and these clients will see a decrease in platelets because they are all used up. We'll see an increase in D-dimer as the body tries to break up all the clots, and we'll see an increase in PT and PTT because the blood is taking a longer time to clot than normal. What are the nursing interventions? Fluid resuscitation is going to be one of the biggest components of septic shock treatment. Remember, we had the leaky holes and things are going to where they need to go and not going to where they need to go. We need to increase our circulating volumes as much as we can to help get blood, oxygen, nutrients to the organs of the body. We want to minimize the risk of injury to organs such as the kidney and help restore perfusion as quickly as we can. We'll also need to collect blood cultures, and remember, these are going to be positive for bacteria, typically gram-positive and gram-negative. Broad-spectrum antibiotics can be administered until the specific strain of the bacteria is identified, and once it's identified, we can use a more targeted antibiotic. These antibiotics will be given intravenously and at high doses. As previously mentioned, in septic shock, hypotension is going to be persistent, and fluid and other medications are not always going to bring our blood pressure up. So we may need to administer vasopressors continuously via IV. These include norepinephrine. We need to make sure the client's blood pressure is high enough to adequately perfuse the organs. Finally, we need to monitor for associated conditions of septic shock. The first being multi-system organ failure, such as MODS. We especially need to monitor the lungs and the kidneys, and we need to monitor for signs and symptoms of DIC. When you combine MODs and DICs with septic shock, mortality rates become super high. So it's very important that we recognize signs and symptoms of complications early and treat them to help the clients have the best possible outcome. This ends today's topic. See you next time. Bye.